Kash, you good to go?
Okay.
So we're just going to start boring on pretty
Okay,
much straight away.
yeah, absolutely. I think shoulder is something that really humbles everyone.
Who was Bankard?
And who was his first patient?
Because if it was me, I'd be like, I think I'll wear my brown pants today. Pete, you promised you wouldn't ambush him. So draw it, Graham, draw it.
Well, you can't come in here talking about zero. Anyway, back to me. We don't use horse's hoof enough.
Where'd you hear that?
In orthopaedics. On the webinar, you just weren't listening.
Biggest worry for the whole time I was in the army is to make sure I left with sort of 10 digits attached. Because people are losing fingers all the time.
A little how's your father as it goes up.
Peter, if it helps, I honestly thought it was a really good question. Subsequently, it's gone to
I hate snakes!
So, welcome to our latest podcast. And this one's a shoulder one. Now, I've got a little spiel in front of it. We've decided that Pete was going to do the intro this time because Kash feels he's boring everyone with his intro. So I'm going to try and do an intro, but I'm bound to fuck it up. So
just read the damn thing.
Okay, so I'm just going to read this out. Here we go.
We'll never hear the end of it from Mike. Just read it.
Okay. Welcome to OrthoHub, where we provide free interactive orthopedic education for all. We're really trying. Oh, this is so cheesy. It's so cheesy.
It is really cheesy, but come on.
We're trying to grow this community organically and really build something with our peers, our colleagues, our friends.
I wrote that bit.
Yeah, it's nice. We try not to take ourselves too seriously. There's hopefully something for everyone. Everyone knows your name? What's that bit mean? What's that about?
That's one for the kids, you know, from Cheers.
Cheers.
From Cheers? That is just,
but you've just...
The kids?
The bar that everyone knows.
Yeah,
right.
But you've just killed it. Now I look like a prick.
Sometimes you wanna go where everybody knows your name.
Please follow us on Twitter, Instagram, LinkedIn, etc. Leave us a review on our podcast app. So it's on all of the podcast forums and platforms, I should say. Please go to YouTube, find OrthoHub XYZ, click on the subscribe button, turn on notifications so that you don't miss out on all the goodness and loveliness that we have coming your way. Did I do okay?
No, that was terrible. But we'll have to go with it.
We've got Graham Tytherleigh-Strong in the room.
Yeah, a.k.a. GTS, a.k.a. the shoulder mechanic, a.k.a. Grey Teasy, a.k.a. the gnome molester.
The gnome molester.
That was unfortunate.
Van Rensburg hasn't forgiven you.
He fell off the balcony.
Yeah.
A.k.a. International Man of Mystery.
So Graham's a consultant orthopedic surgeon, specialises exclusively in shoulder and elbow surgery. Been in practice for over 15 years now.
Yeah.
Adam Brooks in Cambridge, England, for our international guests, as opposed to Cambridge, Massachusetts. He's an honorary clinical fellow at Cambridge University, where he's the orthopedic surgeon to the men's and women's Blues rugby teams. Graham, a real honour for a change to have a kindred spirit here, someone who really makes a difference to people's lives. For you and I, success is, can someone get back to playing Premier League football? Can they do 100 chin-ups? You know, for Pete, it is if someone can sit on the toilet again.
All relative, isn't it?
Yeah, you crack out the champagne and call it a day.
This is success.
Yeah. Well, this is the reason they call it a surgical strike, and what you guys do is carpet bombing.
Yeah.
In the world of pelvic surgery. But Graham and I, we're changing the world for the better, one arthroscopy at a time.
Absolutely.
So I'm delighted to have you here. Thank you for coming. Just before we start, there's one thing I want to tell you.
Yeah.
I just want to say how disappointed I am in you, Pete.
That's a pretty much permanent state of affairs now, right?
Yeah, that it is. But no, yesterday, do you remember on the stairs at the hospital? Basically, I was doing a ward round of all the trauma inpatients in the hospital, and there was I was on the ward, and the patient was looking faint. A nurse cried for help, so I ran over. I literally ran over. I had trainers on, and she kind of managed to. He fell back onto the bed, and I bent down to get his legs to put him back up on the bed. And as I bent down to grab his legs, he vomited all over me. Oh, literally all over my head
to toe,
my arm, my leg, and it was terrible. He basically projectile vomited. So I was on the.
Fortunately, his head is wiped clean.
No, it is. Yeah, that helps. That's the one thing I thought to myself. But basically, I was on the stairs and I was walking up the stairs to shower and change. I ran into Pete, and in this moment,
he told me this sorry story on the stairs. I had very little interest, frankly.
I was in turmoil and distress, and I saw a colleague, nay, a friend, and I thought I'd get a little bit of sympathy. Some of the care, but he was a heartless bastard, and he basically pissed himself laughing, almost fell down the stairs. Yeah. So I've been quite traumatic. You laughed very hard.
Sorry, mate.
Graham, can you tell us your background? Tell us your story.
Yeah, so actually I have been doing missionary work in Cambridge because I trained at Barts, which is
fantastic.
Right, okay,
all the best surgeons,
All the
doctors
best.
probably come
from. Yeah.
Finishing that, I went up to Cambridge to do some SHO jobs demonstrating, then went up to Edinburgh. That's where I did pretty much all of my orthopaedics. I worked in Reading for a while. Then I went out to North America and a little bit in Italy. Came back to Edinburgh, did a senior lecturer's job, locum senior lecturer's job, and then got a job at Addenbrooke's. Hadn't particularly planned on getting back to Cambridge. Hasn't got anything really going for it. It was a pretty parochial place when I first went back there. But at the time, that's where the job was. And it was also very interesting when I went away to North America. It was a time when, prior to that, you'd see most consultants who were specialists, and what had normally happened, they'd started as a sort of really being general orthopaedic surgeons, and then within their department, they'd sort of developed a bit of a specialty. So even the guys who were the shoulder specialists that I worked for still did a bit of general stuff. Then really over the space of a couple of years, they suddenly started to have these sort of subspecialty jobs. So I had no idea that I'd be able to get a job that was just doing sort of shoulders, and I just completely lucked in at Addenbrooke's. There's a guy called Chris Constant from the Constant School.
Yes, Chris.
Yeah, Chris. So he
a dear friend of the show. Yeah.
Yeah, he really.
I've never known anyone who's turned defrosting a body into such a science as he has. He is unbelievable.
He is Mr. In fact, he in his Harley, he's a member of most things. His Harley Davidson chapter that he's a member of. Apparently, on the back of your Harley Davidson, you have to have your nickname. So on his number plate, he's known as Mr. Gadget. So he's got CRC1 and Mr. Gadget. But he was there, and he realised that he wasn't really interested in. He was relatively long in the tooth, and he knew that perhaps arthroscopic surgery was coming, and he didn't particularly really want to get into it. So it's just being in the right place at the right time. So he wanted to get a sort of what was a young colleague at that time, and really just wanted me to do arthroscopic stuff. So it was a dream job, really. So I arrived there. They bought me all the kit. He'd lined up those were the days where there was a 2-year waiting time to get a clinic appointment, and another 2 years for surgery. He'd lined up about 100 stabilisations just to do. And so I just...
On the off chance that someone would come in.
So he knew he needed to get someone in, so he was just waiting around. So it was a stroke of luck, really. So it's just one of those things, and
lovely.
Sort of continued from there. And then he left, and Lee took his place. So from one joker to another. Seriously.
So we'll talk about Lee. Lee was our guest in episode 10.
Yeah.
The first ever one we did in this fine here studio, and boy does he love a tank.
Yes, he likes a tank.
He likes the idea of a tank.
He loves the idea of a tank, but unfortunately, although he claims he's been to Tank Fest in Bovington, I think he's looked at one.
Yeah.
He's never actually been in one, and although he reckons he knows how to control it, the guy has got no idea of what it's like in a tank. It's a pretty rough old place.
Tell us about your military history pre-med school.
Yeah, it's a bit mysterious.
Yeah, so it's not particularly mysterious. Okay. So what the British Army did is they were trying to sort of encourage people to go into the army after university. So they were running these special short service commissions that you could do. And so when I was at school, I just happened to be relatively young for my year. So essentially I took 2 years out, but had a commission in the army. And my father and my grandfather had all been attached to a regiment called the Blues, which are called the Royal Horse Guards, which became the Blues and Royals, and they were a tank regiment. So I just joined that. And so I was actually sort of a tank commander for that time on what were initially Chief and then Challenger tanks. So I just did a couple of years of that, bit of riding around on horses. It was an amazing thing. Fortuitously, the only bad thing that was going on at that time was Northern Ireland, which was, relatively speaking, compared to what's going on today, not a particularly dangerous place.
This is the time of the Troubles.
The Troubles, but the Troubles, so to speak. It's a strange place because you go there and whereas I think in a traditional war, you should know where the enemy are. There you don't really know. But it was nothing like the guys that go out to Afghanistan, all the sort of stuff that they did. So I managed to hit it at a sweet spot where actually, well, I know I've been involved in far more deaths since leaving the army than I ever was in the army as a doctor, and there wasn't really any sort of great danger, so it's really great fun actually. Really enjoyed it, and so yes, so spend a lot of time on tanks. And you
got to fire. Did you ever fire a tank?
Yeah, so I mean, firing it. So basically, these tanks, there are 4 people in the crew. So there's a guy driving it.
Right.
There's a guy that actually has to load the. So you've got these different types of projectiles. Ones that if you want to blow up a soft-skinned vehicle, you have one that explodes, and if you want to go through something that's armoured piercing, you have a really fine needle tip one, and you actually put that projectile up. And then the charge is separate from it, so you have to put that as a separate thing. It's a bit like loading a sort of a traditional sort of cannon.
Okay.
So there's a guy doing that.
Yeah.
There's a guy who's doing the aiming, and then there's a guy commanding it, because it's showing a tank. It's going forward, but the turret is spinning around, so you're separate from that. So I was most of the time as a tank commander, so I'm the top deciding where we're going to go. At the same time, I'm trying to tell the guy which direction to go in, but I'm sort of pointing in one direction, and I'm telling him to go forward. So you have to sort of work out. But then the guy that fires, so the guy who aims it and fires it, all he does is aims it and presses a button.
Right.
And
So you say fire.
So I say
fire in the hole.
Yeah. So I could you can take over as the commander, but basically he's the guy that locks onto it. But they've got all of these fire systems that will track the target. But what they also have to do is, because it's quite a distance, they have to, when they fire it, actually there's a little bit of a delay because the gun has to go up and calculate the trajectory.
Yeah.
So you press the button, and then actually the thing will, the actual
Do the math.
cannon does the maths.
And allow for the trajectory.
Yeah, so you're inside, and it's a massive, great, heavy thing inside, so you can see that swing round, and it does
and
the
it kind of
math and
projectile.
fires it
I
out.
have the same thing first in the morning when I tea.
Well,
Damn boy.
I need to get that. I'm always
Take 2 steps
overshooting.
backwards.
Exactly. But it's funny because as they go along the ground, it always tries to stay parallel. So although the tank's going up and down, there's this gun. So if you go over a hill too quickly, it barrels it into the thing. So it's a really sort of fascinating thing. But it's pretty unpleasant firing that. So I think Lee, if every time Lee fired a shot on his plastic tank or whatever, his make-believe tank, if he actually blows your ears out.
The whole thing shakes,
What's it like in a tank when you're just bombing along? No gun firing, just like bombing along.
It's like having a Land Rover that has got no it's just really rock. They don't put any comfort in. It's just really
no
hard.
air suspension.
So there's no air suspension.
It's
there's no
jarring.
heat. There's no heating.
No heated seats.
No heated
I couldn't
seats.
do
It's pretty unpleasant. And a lot of the guys who are the actual sort of soldiers, because you have to do all the maintenance, and when the tracks blow, you have to. Half of them are missing their fingers because they get caught in the gun, or because it's really heavy. It's a really sort of unpleasant. I decided I wanted to be I had a place at medical school, and I wanted to be a surgeon. So my biggest paranoia for the whole time, actually my biggest worry for the whole time I was in the army, is to make sure I left with sort of 10 digits attached, because people were losing fingers all the time.
Otherwise, you'd have to be a pelvic surgeon.
Yeah, I hadn't really.
Claw hands.
I hadn't realised if I'd had a couple of stumps, I'd have been okay. But I wanted to be more finesse than pelvis. Yeah,
No, that's why you do arthroscopy.
Yeah, absolutely.
Yeah.
But talking about Lee Van Rensburg, Pete and Mrs. Bates made Lee quite a particular proposition in that episode.
Oh, it's a gnoming position.
There's a little bit more than that, but if you could just nudge him, because we haven't heard back from him yet.
We're not having back from Nate.
It has been a bit quiet recently.
Chloe was asking. Chloe's the missus.
Yeah.
Chloe was asking. Is there any etiquette inside a tank? Do you have is there some unspoken rules between the 4 guys? Like around farting and washing and that kind of stuff, or are we kind of beyond all that?
Well, you can't hear anything. It's all on headphones, so it smells of bauxite. It was just actually what you had. The etiquette was, at night you had to sleep on the back decks of the thing. So it's who got the best place to sleep was about the only etiquette. And
outside the
so you can't. You don't normally sleep in. Well, you don't sleep in positions. What you do is you park the tank. You turn the turret round, and if you put the barrel up, there's some back decks. And you can put a tarpaulin over it, and it becomes a little tent.
Okay.
Right.
And you can sleep in that. But the guy who did the loading and ran he was just the guy, the cook. That was the main etiquette for that.
Okay. Good to know. Now, one thing I want to ask about is you love scoping a sternoclavicular joint.
Love it.
So look, I mean, even
How do you get into that?
Well, even
Where
for me,
does
that's pretty niche. I'll scope anything. We talked about me arthroscoping a rectum. In a trauma patient, there was an open pelvis. But the fact is, how do you get into the what starts that off?
Well, once again, Chris Constant, I'm afraid. So when I first started, I mean, the great thing about having someone like Chris Constant around is he's so worldly wise and experienced. If there was anything ever going wrong, you could ask him and he'd always say, don't worry.
Yeah.
Even if it was going
makes you a
bad.
bit fearless.
It makes you a bit fearless. And so I just happened to mention to Chris, I mean, obviously sternoclavicular joints are sort of biggest fear. And I hadn't really come across any, but just in passing, I was thinking, what have you done for sternoclavicular joint sort of problems? He goes, I scoped them. Jesus Christ, a bit ballsy. Anyway, so he just mentioned that in passing, and then
Even though he's not doing any shoulder stabilization.
no, exactly. No, he did. What he didn't do stabilizations. He did AC joint excisions by ramming the scope through He did a superior portal for that, which is just basically
jam it in.
Yeah, jam it in without visuals,
right?
As in the shaver goes in.
Yeah.
So he just sort of mentioned that. I didn't really question him about it. And about a year into my job, the rheumatologists sent us of a young girl who had some sort of monarthropathy affecting her sternoclavicular joint, and the thing was really sort of swollen. If you put a pen torch on it, you could pretty much transilluminate it. You could actually see the fluid inside it. And they wanted a sort of biopsy, including the articular cartilage. So I was thinking, do I do an open sort of thing? So, well, no, Chris told me you can scope this, and I thought, well, actually, quite honestly, this is so big, I'll just use the sort of wrist scope. Yeah. So I just looked inside with the wrist scope and took some stuff out, and then about 3 months later, another one turned up. So I happened to do that. I hadn't mentioned it to Chris, and then in passing, I said, "Oh, Chris, thanks for giving me the heads up on the old SCJ scope. It's really useful." Jesus Christ!
What you doing, man? What are you doing?
I was just taking the piss. And so by then I'd done that. So I thought, well, actually, it wasn't. It wasn't as bad as it was. And actually, most of the people that I do tend to be arthritic, and I don't know if you know, arthritic joints often are actually quite lax because they've got stretched out joint. Yeah. A bit like, I don't know if you scope the elbow, or even when you're scoping around the foot, if you're in arthritic joints, sometimes because of the tissues, the ligaments are stretched out, it's quite easy to do.
In the knee, it's harder because there's just loss of joint space, and it's very hard to get in, and we're using slightly bigger scopes.
Yeah. So I just started doing that. So I got into that. Then I found that. So I worked out a way to take the arthritic bit out, which was pretty easy. Then I noticed there's a disc in the knee, in the sternoclavicular joint, and actually people can get disc tears. So
like a meniscal tear.
Like a meniscal tear, but it's normally sort of
now you've got my attention.
Yeah,
you sold
it's like a shearing injury.
He's hooked.
It's a shearing injury from sort of tennis players, and they just had this clicking sort of thing, and no one had really looked in. There was one report of they'd done an open excision, but the guy was off games for the next 6 months with this massive great scar, never returned to sport again. But you could see it on an MR scan. So I found these people, so you can take that out. And then, not that I particularly wanted it, but because I was sort of put my head above the parapet for SCJ arthroscopy, then all the dislocations sort of came along, which was a little bit daunting. But fortunately, with Patworth round the corner, there's some really sort of brave, gung-ho thoracic surgeons, and they were pretty happy to get stuck in. So then I've actually ended up doing quite a lot of instability. So it was just a side gig that I never had. Right. If you'd asked me at the beginning of my career, do you think you'd be... I said, absolutely no way. No man with any sense would be anywhere near this. And it just sort of fell into it.
And that's your thing?
Well, it's a side gig, yeah. So it's my thing. I mean, it's not even I'd say... on an average clinic, there might be 1 or 2 patients a week with an SCJ thing. They're normally sort of referred from afar, so it's not a massive thing. But
you'll get more after this episode.
Well, I'm not too sure. So I mean, stabilisations, if I do more than 7 or 8 a year, that's pretty unusual.
But then you've got the thoracic surgeons on standby.
Yeah, so what we do is actually now that Patworth, so what we used to have to do for the posterior ones that were sort of actually on the vessels, we had to go to Patworth to do it. But the thoracics, the cardiac and the thoracics have set themselves apart, and the thoracics have their equivalent of a trauma list, which is really for cancer sort of thing. So it's not sort of super urgent, but they need to be able, someone gets diagnosed with a sort of lung tumour, they need to be able to do it that week. So they tend to have open lists where they can just chuck people in. So actually I can normally phone them up and say, can we get that done? And normally within a day or two, they've got a list available.
So you've got their support on standby.
So I've got their support, and now they've actually moved to Adam Brooks. So I just go to their theatres.
Because if it was me, I'd be like, I think I'll wear my brown pants today.
No. So actually, well, I've helped them do a couple of these chest deformities where they've got to do all the ribs, but they need an osteotomy of the clavicle. So I've helped them a couple of times. So I realised the stuff I'm doing is entry. There've been a couple of times there've been a few minor bleeds, but actually this is entry level to those guys. So, they're probably laughing at me being such a wuss, man up, man. It's just an artery.
We're going to talk about shoulders today. Eponymous names, just before we go any further.
Oh yeah.
We had we talked about Essex Lepresti. And I had no idea Essex Lepresti was formerly of this parish here of the Whitechapel.
He was one dude.
One dude in Le Chapeau Blanc, as we call it. And
nice.
So now I've taken a further interest in these. So Hill Sachs, Pete, one person or two?
I had that down as 2 people.
Yeah, I think I've got that as 2.
2 people, yeah. I've got it here. Harold Arthur Hill and Morris Sachs, who are 2 radiologists in San Francisco.
Right.
Quite impressive.
Yeah.
Bankart. Who was Bankart?
Who was Bankart?
And who was his first patient?
There you go. I haven't got that bit. Shit.
No.
It's not on Wikipedia.
I did tell you guys this is going to drain my knowledge very quickly.
No. The thing that's quite impressive about Bankart was he was literally not from far from here. He was Mount Vernon Hospital. The thing that's quite impressive was that he did a full operating list in Mount Vernon in 1951, and he died at the end of the list, age 72.
72.
Is that how you like to? Is that how you like to go out, Pete? End of a trauma list in Theatre 9.
Well, it makes you famous. Yeah, I'm not sure your missus would be delighted with that, would she? Unless she's got fed up with you a long time ago.
She's got.
Which she might well have done, I guess.
Who was his first patient?
Well, apparently the first Bankart repair he did was on his house officer. I mean, that is desperate for a reference there, right?
Yeah, that is. Yes.
Yes, I need a publication, boss. Yeah. Right, okay. Well, what we're going to do, we're doing a case report, but it's on you. Yeah.
The thing I didn't realize, so actually Perthes described it first in 1906.
Sometimes it's called a Bankart Perthes.
Is it?
Yeah.
But I imagine everyone went to Perthes, piss off. You've got everything else named after you. You greedy bastard. You've got enough.
Yeah, there's some of these guys, like old Jupitron's got his name on a few
he has.
things.
Yeah, Pete knows it well. Show me you. If you could rename Pete, if you could rename one medical condition after yourself as an eponymous, what would you have?
Crikey. No, I wasn't expecting that one.
Sorry,
that is left field.
Yeah. A medical condition.
Medical condition. Graham, anything? I think personally, I'd go for priapism. Strong, upstanding member of the community. I won't be beaten. Strong like a bull. Yeah, a Bates would be some sort of
be galloping knob rot.
It'd be some sort of weak and ineffective post-nutrition dribble. Just leaves you kind of damp and feeling a bit uncomfortable for a while. But no, it's all good. The webinar. Someone said on Twitter afterwards that it was like the Mount Rushmore of UK shoulder surgery, with you guys all on the screen. I felt it was more like the Easter Island heads. But sentiment was genuine. How did you find it?
No, it was great, and
this is the orthohub webinar. Sorry.
No, there is only one webinar, isn't it?
Yeah.
No, it was really good, and it was. It's a nice opportunity. A lot of the meetings you go to, you only get 5 or 10 minutes, so it's nice to have a bit more time to chat. And those 2 guys, Hannah Mullett and Len Funk, I've sort of known them for years, and we've done a lot of meetings together. So I thought it was really good, and Olivia being there. I mean, it's fantastic. I think the only thing that could enhance these, the one thing I'm sure you miss on the webinar is just seeing people's faces when you're talking to them. You can get a little bit of an idea whether people are really understanding. Sometimes you can just sort of change the way you're talking. You tend to focus on someone, but I thought it was really good.
It's just look, these things have been forced upon us. It was something that we ended up doing because of COVID. Things are changing. The way I love going to meetings. I love seeing colleagues. I love the social side around it. But for now, the fact is it's accessible. It's all on YouTube. Yeah. People can drop in and get what they want at any point.
Yeah, but I think webinars. A lot of people are trying to do a lot of stuff out there. But I think the relatively unique thing about the orthohub one is that it really is a different format, because you've got sort of 3 pretty established guys talking in a relatively niche area, but for a decent amount of time about stuff that really covers the whole sort of subject. A lot of these other webinars tend to be everyone's repeating themselves. Everyone wants to have the syllabus of whatever it is, and so it's very difficult to really go out there. Back in the day when they used to have those things called books, and you used to be able to see what was a quality book, and you could see, you could flick through the cover, and you knew straight away.
I've still got some books at home.
Whether that thing was quality or not.
I don't think I have any.
You know whether it was
ours are all out in the shed.
I mean, everything's. My whole life is paperless. The only I think the only paper thing I've got at home is like the Littlewoods catalogue. I'm not getting rid of that.
That's under the bed.
That's not going.
But nowadays you can't really you could tell the quality of a decent, that was, I'm going to read that one, that's really the textbook I need. Whereas nowadays it's such a wash, and you can't even, it's quite difficult to flick through. I suppose you can look through a YouTube, you can flick through a webinar talk, but you can't really do that. So it's quite difficult to know what you're going to get just by flicking through. And
I agree.
So having something that is got a good sort of brand is something I think that it's going to be encouraging for people. Right?
So we're hoping that something that's stamped with orthohub, people will know that it's from a genuine place where it's all about the community. The thing that I really liked about your one in particular, but most of our webinars, has been that a lot of the attendees were consultants. A lot of questions come in for pre-established shoulder surgeons, and I thought this is amazing. Yeah,
but I think that maybe, I think shoulder is something that really humbles everyone. And so actually, when you go to most shoulder meet, I know you knee guys, whenever you go to the meetings, so I've done 1,000 ACLs, every player.
We're really quite humble and down to earth.
None of them have ever failed.
You are
never failed.
I've never had a complication.
Yeah, well, exactly. Whereas in shoulders, if you haven't had a complication, you probably haven't done enough. And a lot of the stuff, particularly around the rotator cuff, a lot of the tissues are degenerate. So even if you do a great job, you never know how well. So everyone is pretty sort of heads up. And actually, when we're bragging, it's about the biggest screw up that you've done. And so actually at all of the meetings, you're always learning stuff from other people, even in the audience, because I think there's such a wide breadth. So actually most of the meetings we go to, it's a pretty there's a lot of interaction between sort of consultants.
There's a real community, the shoulder community.
Yeah, and you genuinely learn, every time you go on it, whether you're sort of faculty giving a talk, you always come away learning something. And it's not just from the other guys on the faculty, often guys who are the delegates you chat to have all got sort of different experience.
Well, it's interesting. We did a webinar on tibial plateaus last night, and there are guys who I've been to as a trainee, listened to them on stage, and they were in the audience and saying they learned some tricks. Not for me, but they learned stuff last night. And I thought, well, that's great. We're actually offering something there.
I think that's the thing. It's just, I think the way training has slightly changed in the UK, whereas now you tend to be on a training program, so you're probably just going to be in one region, and often consultants, the guys get appointed as consultants in that region, so you do tend to get a slightly blinkered view, whereas different regions in the country have got perhaps slightly different ethoses.
Yeah, but even across London.
What's the plural of ethos?
Ethos. There are a number of different ethos.
There are,
whatever.
Philosophies.
Yeah, exactly.
Tell us about, let's talk about first-time dislocators. So Hanan gave us an awesome talk, but you can just tell that he's a guy who deals with Gaelic footballers, elite sportsmen, and actually that's quite a long way away from who are coming to him absolutely hot. They dislocated yesterday or this afternoon, and they're coming to him right now. So he's getting a group of patients that you don't normally see in your average day-to-day practice.
Yeah, so so what we do know is that the younger you are, you dislocate your shoulder, the chance you're becoming a recurrent dislocator.
And that goes right down into your teens, right?
Yeah, well, really at teens. So if you dislocate at 13, 14, there's almost a 100% chance that you will re-dislocate again. And it really and if you're doing contact sports, even at a recreational level, you're going to run into trouble. So so the professional guys now, they come to you straight away, and they just know there's such a high chance that you're going to re-dislocate.
I didn't realise why until Len explained. I had no idea about this anterior inferior ossification centre in the glenoid. Closed at 25.
And so basically, if they try to rehab without surgery, they're normally off for the rest of that season. They play the first game at the beginning of the next season. They dislocate they're off for a second season.
They're done.
Whereas, well, they're sort of done, or they've had 2 seasons off. Whereas if you bite the bullet straight up, you have the surgery done, and actually the rehab is about the same. You can get it done within a few days arthroscopically. So in effect, you've got 1 season out. The redislocation rate is still, there's a sort of a 20% chance if you've had a soft tissue stabilisation and you're a contact athlete, but that's only 20% compared to 100%. So a lot of the guys who are very serious at sport are straight in there. And the more average people that come to the clinic, it really just depends what they do. So someone who leads a sedentary life and it's their non-dominant arm, they're fine. But you tend to see a lot of the difficult thing is particularly boys, and often their parents are living slightly vicariously through them. They're maybe just the captain of the rugby. It's the school first 15, but it's an important thing. If you were to catch them at 30 when they've started to sort of have a family, and it's not so important. You get a gut. They wouldn't. If you said to them, "Do you really want that operation?" They wouldn't. But at that time, their life really revolves around it, and it's a quite a difficult. And
a lot seems to hang on it at the time.
Yeah, and so that was the sort of the thing where. So Hannah and Len were talking about the really professional thing, but actually there's this group that's just below that where the kids are. It's so important for them. They feel their life revolves around it. Their parents have got a little bit of insight, as in they want their kids to be happy, but they also think, do you really want to sort of go through that? So it can be quite a difficult sort of area, but when it happens the second time, it's easy.
It is interesting because you get loads of these kids who are 15, 16, the parents are kind of convinced, they're at an academy, they're going to be a professional footballer. Yeah. And, you're kind of like, it's not always the case. I mean, the attrition rate is so high.
I guess the target audience, the thing that people really want to know about is not the 13-year-old budding Arsenal player or budding Harlequins player. It's the 26-yearrold occasional weekend warrior who's.
So can I ask you this? Sorry, budding Graham. You're in fracture clinic, right? You've got a 26-year-old guy who. You've got a 22-year-old guy, who's had a first-time dislocation. Yeah. And you've put it back, and he turns up in a sling. Yeah. He's had an X-ray before and after reduction. Yeah. At that point, are you investigating any further?
So 22-year-old guy, actually 22 is probably the age that you'd still be a little bit worried. Once you get to 25, it's going to be it's really a case to chat to them. If they are a recreational sports person or they've got a manual job, at 22, there's a fairly high chance that they could run into trouble if you don't sort of fix them up.
So you're investigating with an MRI?
I don't. If you want to fix them up arthroscopically, you've really got a sort of it's really a 3-week window to do it acutely. Once it's 4 weeks, you've got such a lot of fibrous sort of tissue. If you actually try to go in and do it, it's not so successful. The tissue tends to tear. You can't see anything. So if you're going to fix them up, you really need to do it within the first 3 weeks. Otherwise, what I'll do is we'll run them non-op, see them at 3 months. Sometimes they're feeling stable, but some of these guys generally feel that they're not great, so perhaps do a more delayed thing, sort of 3 to 4 months down the line. So the way it works in the NHS, it's the chance of getting an urgent MRI scan done on someone you see with a shoulder problem in the fracture clinic to get that back get it done.
That'll burn your 3 weeks.
Yeah, absolutely. Yeah. So for those guys, I have a chat. I mean, the fact that it's come out, there's bound to be at least a Bankart tear. You can sort of assess the amount of bone loss. And actually, I mean, maybe it was Cambridge, but a lot of the patients you come to, I can have a chat. So basically, I try to present to them the sort of rough evidence, and they think about it. I put a little bit of pressure on them. I said, look, come give us a call tomorrow, but you've got to make a decision. If you want the surgery, you need to get it done in a couple of weeks. And I'd say about a third of the people who aren't the real sporty people, but a third of the people that are likely to have problems actually decide to go for it. Okay. And about 2/3 don't. And about a third of those I'll see next year with another dislocation, and then I'll do them as recurrent dislocators.
Okay. I'm with you. So you're not ultrasounding these people?
So not in the for an acute one. You don't really do that. Ultrasound ultrasound isn't really going to help you.
Okay, I was just thinking of saving some time. But tell me this. I don't really. My clinics are, lower limb. I don't really see shoulders. Shoulder dislocation.
Thank God.
Thank God for that. Yeah.
I thought those referrals had died down a bit.
Yeah.
What do they say?
But the thing that traditionally you'd put them in a sling. You'd say go away for 3 weeks in a sling, do some pendular exercises, have some physio, off you go, and we'll see you again in a couple of months. Is that still the thing?
Not really. So there was a guy called Havelius. He did a study in Sweden, and actually we learnt a lot about this redislocation rate from his study. His study originally, he just wanted to know: do you put them in the sling for 3 weeks or longer or less? So he did a randomised study, and he said half of you guys stay in for 3 weeks, the other half of you come out of your sling when you feel like it.
Is this the one that had the 25-year follow-up?
Yeah.
Study. Right.
And so all he was doing originally was he just wanted to see what the outcome was of that, and he found that actually there was no difference on redislocation rate whether you had the sling on for 3 weeks. It was just how long you felt you needed it for.
Okay.
So I'd say one of the bigger problems ultimately, particularly when you've operated for instability, so most shoulder sort of stuff, actually it's not they're going to redislocate, it's they're stiff and they don't get going. So actually, I'm sure in all of our practices, as time goes on, actually the length of immobilisation I have is decreased as time's gone by.
Exactly
so it's a sort of a stiffness thing. So actually, for anyone who's dislocated their shoulder, they come up, I'll just say, well, you can get going as pain allows. So some people are very paranoid and they'll stay in for 6 weeks. Others get themselves going, and then send them along to the physios. And some people seem to be able to sort themselves out. And
what are those physios actually doing? Because we say go to physio, but what
they're really doing is they are trying to. So if you've got an unstable shoulder, sometimes the scapular muscles will try to reposition your scapula, try and compensate for that. So it's really partly improving scapular stability to make sure that you've got a strong platform, and then just because you tend to get most instability, there's a sort of due to laxity, a traumatic cause, or what's called a sequencing cause, where the muscles don't quite work, and it's really
so-called muscle patterning.
Muscle patterning. So a lot of the traumatic ones don't have muscle
Good
patterning,
knowledge.
but they can develop a little bit of instability. So it's really just sort of re-establishing the scapular control and their cuff strength and muscles, and just making sure that they regain their strength. I mean, there's a study going on now.
So is it almost a case of not allowing them to fall into bad habits, sort of thing? Like not allowing some weird muscle pulls to become established?
And probably more to, particularly for the young guys, really control them. Say, look, actually, what you don't need to do as your first thing is to lift the heaviest weight you've ever lifted, throwing your arm. Just sometimes it's more just containing them and just sort of slowing them down. Yeah. But in truth, if someone is, if you've got a young guy who's dislocated, the physio is not going to, if it's going to come out, it's going to come out. It's not going to make a big difference.
If these guys, when you see them, if they do collision sports or overhead sports, then are you more aggressive in pushing them towards surgery?
Yeah, certainly collision sports, I'd say. Obviously everyone's got a choice, but I'd say to them that, the chances, if you go back to rugby, the chance of this happening again, pretty much 100%. It's not a problem because you can then get fixed up, although ideally you do get the best result if it's first time. Second time it's not the end of the world. I don't particularly push them I just present them with the evidence and say that I'm happy to do that. I'd hate to think I've forced someone to do that. But you're right. So
but the fact is, I think the one thing is, as we get more experienced, with time you become more conservative, and yet you become slightly more emphatic with certain ones who you know are going to run into trouble.
Yeah, I think that's very good. I mean, that
you get a little bit cross with them when they say no, I don't want an operation.
But they get cross. But I know what you mean.
But there is something that's just coming out, and looking at osteoarthritis down the line. It's really interesting instability because. A lot of the revision stuff that I do, and even some of the what's called post-capsular osteoarthritis. So arthritis is the result of stabilizations that have been too tight, so they've made the balance, and so they've
overcooked it.
They've overcooked it. These guys are sort of 40 or 50. I'm seeing their practice because they had their operations when they were sort of 18 or 19. So actually, instability it's got a lot more interest in it, but actually still we don't have that much knowledge of people really far out because we haven't followed them. But what is becoming evident is that you're seeing these guys in their 40s and 50s who are getting arthritic change. It's often asymptomatic on their plain x-rays, even if they only had one dislocation down the line. And in that Hevelius study 25 years down the line, they found that 2/3 of the patients had osteoarthritic changes, and some of them had only had one dislocation compared to an age-matched group who didn't on the other side. So something's going on, and we're actually just doing a study, and we can see actually just after one dislocation there's a new MRI sequence. You can see that you've damaged the articular cartilage. So it probably ultimately may be that actually to save your, not to save your shoulder, but actually dislocating too many times, although previously we thought that was just a bit of an inconvenience.
Yeah,
actually,
you would often say, 10, 15 years ago, go carry on. If it dislocates 2 or 3 times, we'll think about it.
Yeah. So I think now it may be able to give people perhaps a stronger steer to say, well, it's not just that it could come out again, but actually you are significantly increasing your chances of getting an
each time it comes out. It's a bad gig. Yeah, and some of the reconstructions are also associated with arthritis down the line. And where do we think that is that because of the surgical intervention, or is it more because of the natural history of having dislocated your shoulder?
I think it's a combination of things, but certainly the ones that are really sort of bad ones, something which is a famous one we know is called the putty plat. And essentially for the putty plat, what they really did is they just really tightened up subscapularis. So basically you couldn't externally rotate, so you couldn't actually get your arm into the position where it would dislocate. So it wasn't really an anatomical. So what we do know is the ones that you're really going to run into problem are the ones that are non-anatomical repairs. So it's a bit like any joint. If you don't balance it out,
you've got abnormal stresses.
Yeah, so those are the ones definitely. But a lot of the time is issues with sort of implants. So some of the metal implants which poke through. Actually, some of the sort of the plastic and the other one. So there's something to do with those. So those are part of the reasons behind it. But I think you're right. I mean, so some of it is the result. Someone has had surgery and then they subsequently get arthritis. If they hadn't had the surgery, they would have probably got it anyway, whether it would have been quicker or slower.
But if it were to dislocate again, they could get a Hill-Sachs, a bony band a more significant pathology, cartilage.
Yeah. So the guys who have a dislocation, they've got, say, small Hill-Sachs or small bit of bone loss, you can just repair the capsule and there's enough, but there's a sort of a threshold of bone loss beyond which, even if you repair the soft tissues, it's not going to be stable. So
how do you quantify that?
We normally look on the glenoid side. So when you dislocate, you knock a bit of the glenoid off. So traditionally people thought that if you'd lost about 20% of your glenoid from the front, it would then dislocate. But then they realised that actually that Hill-Sachs lesion is created because it causes a divot. So actually you can have less loss at the front, but if you've got a Hill-Sachs lesion that lines up with it, which is called an engaging Hill-Sachs lesion, the two sort of combine. So actually you don't have to have that much loss at the front. So now we tend to try to look at both of them. We look at the combination of the Hill-Sachs and the glenoid bone loss. But it's a real sort of it's a real grey area, and it really depends on your attitude towards whether you like doing bone. There's the ones that definitely are soft tissue, and the ones definitely got a ton of bone loss. Big grey area.
For everyone listening at home, Graham is basically using his hands as a ball and a socket. And Pete, as he explains it to like a 4-year-old, and Pete and I are nodding along. We really get this. We really get this.
Well, this is the type of
so engaging Hill-Sachs.
Perfectly clear now.
You say engaging Hill-Sachs, I'd have to think about it. The minute you do that with your hand, I bloody get this. I can do this.
Yeah. Bear with me, going to that 26-year-old or 32-year-old. So it's further, just and on a weekend warriors, he likes to go for a bike ride or likes playing a bit of Sunday league football.
So first time dislocation with those guys, they're probably going to do sort of fairly well, and I certainly wouldn't be advocating them jumping in with an op straight away. See how they get on with their rehab, and they'll go one of 3 ways. One, they'll just have no problems. One, they'll just have sort of an element of instability, sort of doing certain movements. In that situation, you perhaps then get an MR scan or an MR arthrogram to see what's going on. And then there'll be guys that will subsequently have another dislocation down the line. So a lot of basically the older you get, the less problems you are until you get to about our age, because then you've got to rotate. You're not going to have issues with dislocating your shoulder, but you're
into rotator
tell your
cuff
rotator
action.
cuff at the same. So if you dislocate your shoulder as you get older, it's the rotator cuff that gets torn. It actually is probably more 50 or 60.
Actually, Pete's done both his shoulders. But Pete's a bit older than both of us. So.
Proper ancient. And what about bony Bankart? So let's say you have that same 32-year-old with at this time he's knocked off a bit of bone.
Yeah. So once again, it's really the size of the bony Bankart. It doesn't sort of correlate, but to a certain extent, the first is just the violence of the dislocation. So actually, it's a rule of thumb on a plain X-ray for a first dislocation. If someone has got a significant Bankart, you're really going to see it almost. It's often, sometimes patients will come to the clinic and the diagnosis will be an inferior glenoid fracture, which may in fact be a large avulsion of bony Bankart. So actually to have a really significant, I think to have significant glenoid loss as a first-time dislocator at that age, where you're really going to run into trouble and you're going to have to do something about it, it's probably something you're going to be able to see on the X-ray when they come the first time. If you're struggling to look for it, then it's probably not going to be anything.
Sure, but I guess my point is, if you see it on the X-ray, there it is. There's a bony Bankart. And they're now back in joint. Is there a scenario whereby that person could actually not be unstable in the future?
Yeah, absolutely. So it's the size of the bony Bankart. So some people will not have instability. So it's not an absolute given. And to a certain extent, it depends what they do as well.
So with these bony Bankarts, are they getting CTs or MR?
Yeah. So once again, there's a new. I don't know if you come across zero echo. Yeah.
I want to know about it.
That's
that's where it's going. We planned this.
Yeah, exactly.
Zero echo MRI.
Yeah. So we're just started. So actually, it's quite a complex sequence, and you have to have a special coil. So we're just starting to get that at Addenbrooke. So we can't offer that straight away. So basically, at the moment, you've either, depending on the luxury of what you either go MRI or CT.
And traditionally, bony Bankart would be a CT, right? For bone.
Although sometimes you're also interested. It depends how big that bony Bankart is. So that can sometimes just be a small flake, or it could be a big chunk.
Big monster.
So if it's a small flake, you're probably going to go more MR, arthrogram, to see what's happened to soft tissues. If it's a big chunk, then you'll probably go along the lines of a CT. But the zero echo MRI, you can get CT quality bone views off of an MR scan. So you can get
what's the basic science of it?
I've not a clue.
Okay. So
you promised you wouldn't ambush him.
So I
draw it, Graham. Draw it.
Well,
you can't come in here talking about zero.
I knew it was complicated when I went to see. We've got a new radiologist who's come from Leeds, who's a consultant there, a chap called Andrew Granger, absolutely super guy, really into sort of shoulder and MRI, really enthusiastic. He knows everything you need to know about MRI scans. So when I went to see him to talk about zero echo MRI, I asked him that question, and he said he needs to speak to the physicist. So I think it's something that's a little bit more complicated. I think probably these radiologists are a little bit brighter than
we give them credit for.
Then we give them credit for. I can do that report.
Clinical correlation is needed.
Exactly.
I can do that every report.
But I think actually when you really get to chat to them, you realise that actually there is potentially a lot more that you could see on your scans that you organise if you really speak to them and ask them about their sequences. And
I'm curious about zero echo now, whether or not it can be done from a standard sequence or from a standard MRI that we have, or is it a special scanner?
Yeah, so it's not necessarily a special scanner, it's the software that goes into your scanner to run it, and the actual gantry angles, and that's actually where so actually it's like one of those things you buy the hardware, but where the companies are going to make their money are going to say you're going to.
But actually, it's a
really
software
expensive
upgrade.
Software upgrade. So that's where I think the gift that it was always giving.
Just explain to me what an ALPSA lesion is.
ALPSA lesion, so that is...
Well, not just ALPSA, we want to know about slaps and pastas and pistons.
So an ALPSA fits... And ALPSA fits in with a little bit with what Len was talking about. So it's called an anterior labral periosteal sleeve avulsion. So
sounds bad.
It sounds bad.
Say that again, please.
Anterior labral.
Yeah, I got that.
Periosteal sleeve avulsion.
Okay.
So really what it is, it's in scalicity immature. Rather than getting a bony Bankart, actually the periosteum peels off. So actually, rather than a little bit of bone peeling off, actually just peels off the periosteum. And so that just rolls.
So for a young dislocator.
So 16-year-olds, they'll probably have what's called an Alpsa lesion. So you'll see the capsule sort of peel back, and actually it's got a bit of periosteum rather than bone. So if they were skeletally mature, it would have been a bony bone cut.
And that's worse or better than a soft tissue or a bony bone cut?
They tend to do worse. Because what tends to happen is then actually it will then heal and grow back in that position, whereas with a Bancartle's
so it's baggy.
Flick back, so it's a bit baggy.
Right.
So and actually when you fix them up, you have to actually you have to go a lot further back to mobilise them, so they're a little bit trickier to do.
Right, because the periosteum heals like that. Doesn't it?
Yeah, exactly.
Yeah.
And so
slap lesion.
That's a superior labral anterior to posterior tear. So if you look at the glenoid as a clock face, actually all of the instability dislocations probably happen between 3 o'clock and 6 o'clock at the front and 6 and 9 o'clock at the back. Okay. So the top bit, which is the superior part of the labrum, which isn't so important with stability with regards to dislocating backwards and forwards, but it's more to do with sort of subtle stability, particularly sort of throwing and overhead sort of things. If you damage that bit at the top, that's called a superior labral anterior to posterior tear, and it's also connected to the long-headed biceps. So it was really sort of came out of the States for baseball pitchers and throwing, and it was something that when it first came out, everybody was getting fixed up, and it's turned out that actually people were really overcalling them and fixing them.
They were all the
States.
rage back in the day.
In America, everyone was getting them. Now, when I first started, I'd do 40 or 50 a year. I'd say probably they had slap tears, but I didn't actually. It turns out probably could have got away without doing them. I'd say if I do more than 10 a year, that's pretty unusual, and that's quite a specialist volume of people that really get them. You can have a lot of people when you scope people down the line. You can see quite a lot of labral pathology in older people who are having cuff repairs, and you don't have to fix them up. So you don't always have to fix up slap tears.
Yeah. So it's almost a natural history thing rather than a pathology.
Yes, pathology. You get it by injuring yourself, but actually it doesn't always cause problems down. It doesn't always cause problems down the line, and actually fixing them, you often end up with a very stiff shoulder. Okay. And sometimes if you do a biceps, because the anchor of the long-headed biceps is onto the top of the labrum, and so sometimes the problem is that the biceps anchor has been affected. So as people get older, you're probably better off doing a biceps tenodesis and defunctioning it. They don't have real instability, so it's something. It's a little bit of the throwing shoulder that's a minefield.
Yeah, we're not going there.
Yeah,
we're not going.
Absolutely.
Yeah.
Hit me with pasta.
Pasta. That's a partial articular-sided. An articular-sided partial thickness tear for the rotator cuff. So that's a pasta lesion.
Nothing to do with what we're talking about, Pete. Now you look
totally irrelevant.
Now you look really stupid.
Partial. A partial.
He made me say that.
Partial.
Pete, ask him about this.
It's a partial.
I actually pointed to it. I go, Pete, ask him about this.
So it's called a partial articular-sided rotator cuff tear.
Ask him what an ACL is.
I don't know what that is.
Tell me this. So
it's pretty straightforward.
It's a load of bollocks, I tell you that.
It's just a couple of letters.
It is. Yeah, it is pretty straightforward. Going back to Pete's. We talked about this 30-year-old guy, right? We're talking about playing social rugby, what have you. If you're treating him conservatively, which we said we probably would, at what point would you let him play rugby again?
Yeah, I mean, I'd say for these guys, it sort of depends where they are in the season. I'd say that you probably need, even with an accelerated rehab, you probably want to give yourself 3 months before getting back to 3 to 4 months before getting back to full contact. You need to sort of build yourself up. So if it was something that was, say, happening sort of the beginning pre-season, August, September, I'd say, well, realistically, you might be getting back in sort of January, February, although the ground hopefully is going to be wet and it's not going to. But anyone who's getting anything just before Christmas, I'll say, look, you're out till, realistically, think about pre-season next season. Right,
so I've got an 18-year-old rugby player who I serve up to your clinic.
They're getting younger.
I just want to take an extreme.
Male or female?
It's male. It's rugby. It's male. It's rugby, and he's a first-time dislocator. Was playing rugby, and what you're telling me is that there's a high chance that you're going to not talk him into surgery, but he's probably going to surgery strongly
present the evidence that may want to do surgery.
Yeah, right. Okay, I take the same 18-year-old, except now it's a girl who's dislocated playing gymnastics, and she's incredibly hypermobile.
Yeah. So it really depends whether she's had a traumatic dislocation. So you can have hypermobility, and there's this.
But what does traumatic mean?
So it's actually torn the labrum. So if you've got an element of laxity or muscle sequencing, the reason the shoulder's coming out is because it's too loose and it's flying in and out. Then actually no surgery, even these plications, you realise don't really work. The only way you can really treat that is by some sort of physio. If they have a traumatic, so it's come out and it's actually ripped the labrum, so actually there's a mechanical bit that's broken, which you can have on top of that. You've really got to fix that mechanical bit and then address the other bit. So really, if it was an 18-year-old girl, if there was a history of trauma and it's come out, those are the ones you definitely want to get an MR scan to see whether they've got. So if they have got a Bankart tear, then you could try rehabbing them, but they may not get all the way. You may want to fix that up. But if they haven't actually got a labral or capsular lesion, then actually if you start doing surgery, that's not going to be a good way to go.
So there is seriously a bunch of people who will literally dislocate whilst for the first time in a completely atraumatic way. Is that a thing?
Yeah. So the sequencing people, they tend to be sort of teenagers and girls, and actually it's really the things that really keep your shoulder in joint are probably all the muscles around it are acting a little bit like guy ropes in a tent.
Yeah.
Are really having to always be pulling in sort of sequence, and they are super strong. So no capsule's really going to be strong enough to fight against that. So when you have patterning, it's really those muscles are out of sequence. So whereas one should be relaxing a little bit eccentrically, the other one's concentrically pulling. Actually does the opposite thing. So it's actually literally the muscles pull the ball out of the socket and they pull it out that way. So it's actually the muscles aren't working in the right sequence.
So the muscle patterning people, but I had in my head that the muscle patterning people they became muscle patterners because they were unstable in the first place, and so the muscles went a bit crazy. You can kick off that way. They
can just go crazy. They often do have an element of sort of laxity as well, but they're a definite group. So often I've got a great physiotherapist that I work with who actually started off as a paediatric physiotherapist, and it is pretty useful because probably of all the people, they're the toughest group of all the shoulder people that you've got, and they tend to be sort of teenage girls. And I'm not saying this all the time, but often there maybe when Natasha really chats them and delves into it, there's something else.
There's added issues,
exams coming up, which may or may not be part of it. And she'll work on them. But we say to these girls, it's sort of 6 months to a year. They've really just got to bash away. But as a general rule, they get better. And the thing that I've noticed is I don't really see anybody over the age of 20, 25. So I don't know whether it's something that automatically settles itself down. But you don't tend to see people becoming sequencing after 25. And there are people that aren't treated. Who you don't see. I'm not sure whether it's a phase or.
It's fascinating you say that because we see very similar patterns with the patellar instability in adolescent girls.
So it's a similar sort of.
Here we go. You just couldn't leave it that long. I'm amazed we've made it like 40 minutes in without mentioning the knee. It's the same. Anyway, back to me.
But
Graham, you stop talking. So let me tell you about Kash Attar.
But it's really it's a similar sort of thing. So the patellar instability and the muscle sequencing. These are the sort of guys that they're going to be your frequent attenders at your clinic unless you've really got a solid wall and say, look, this is a non-surgical thing, it's a physio thing. Otherwise, they're the guys that are going to be turning up at A&Es left, right and centre, and they could really be clogging your clinics up. So I think as time's gone by, we've got a much strong. I think we're able to really define these pretty early, tell them where they need to be treated, and surgery isn't going.
How do you? Can you tell from your examination a muscle pattern? What do you look for in your examination of someone who you think they might just be lax, but this might be muscle patterning? How do you tell?
You can see the muscles pulling. There's a sort of certain pattern. They'll move their shoulder in a jerky way, and you see it'll come in and out as they go along, as they move.
Like they're body popping.
Yeah, they are. So they tend to have a sort of dominance. They're sort of different various types. It's normally pec major or lat dorsi that are dominant, and as they elevate their arm, you'll see they'll do it almost. It looks like a funny little sort of
a little "How's your father" as it goes up.
And sometimes they can control it. Sometimes it can go in. So it's a visual thing. So it's just obvious. You can see
and
it.
Do those guys get arthritis down the line?
We don't really know. What's the amazing thing is I suspect not, because amazingly, when I have ended up scoping these people that have dislocated all of these times, their articular cartilages are normally pristine. They don't have hill sacks.
Yeah.
They don't have
How bizarre.
Yeah, I mean, I think it must be to do with the way maybe it's slowly glides out
Yeah,
rather
it's
than.
more,
I don't know what it is, but interestingly, they don't. You'd have thought these joints would be smashed to pieces. They're being in and out all of the time, but as a general rule, they don't tend to have that.
Right. So the traumatic thing really, and that was something I got from the webinar, was that the ones that are the worst are the ones often that's the hardest to get back in joint.
Yeah. So that's a sort of an indication about the forces that have gone into it. Yeah, I mean these rugby guys, these young guys. I mean their joints are absolutely mullered. You know they are going to run into problems.
Who's more likely to get a Bankart, a younger patient? A Hill Sachs. Who's more likely to get one of those? A younger patient or an older patient?
Probably a younger. I mean, I think it genuinely is to do with the force of the dislocation and how it comes and how it actually the muscles pull it back. So as a general rule, it's going to be someone who's a higher mechanism of injury, really. It tends to be a younger patient.
Talking of injuries in the contact athlete, Len Funk talked about this anterior glenohumeral instability, and he told us that the recurrence rate return to pre-op level of support is much higher with a latter J procedure. Yeah, just not everyone knows
better. So the
better.
latter J is better. Yeah.
So not everyone knows what latter J is.
Go on,
hit us explaining.
Hit us with latter J and the difference between a latter J and the Elan.
Eden Hibernate.
All right.
Very good. Yeah.
And it's really funny because when you were talking about the Ibahibene, so it is Eden Hibernet, right? But you can. I honestly thought you said Ibahibane. So I WhatsApped Adrian Carlos. And Adrian, what the hell is it Ibahibene? And he's like, what are you talking about?
I know what you're talking about, mate.
That's also like a Japanese sushi chef. Eden Hibernet is
Eden. It's spelt Hiberneti. Hybinetee.
Yeah.
Okay.
So basically, the latter J, and I think it's sometimes called the Lache Pate procedure. I think he may have even been a gynecologist, but in France. But basically, that and the Bristow procedure are the same things. It's where you take the coracoid off with the conjoint tendon attached, and then you bolt that on to the front of the glenoid.
Extracapsular.
Intracapsular. You bolt it on, and you can repair the capsule. So ideally, you bolt it onto the front. You bolt it onto the front of the glenoid, and then you'd repair your capsule onto the remaining bit of the glenoid, and so it is then extracapsular.
So it's almost like putting a block in front of a door or a ball to stop it rolling.
Yeah.
Yeah, and then whereas the Eden Hibernate is where you just take a bone graft, so you just bolt. So you normally take a bit of iliac crest or allograft.
As a chunk,
as a separate chunk, and you bolt that on, so you don't have. So the thought that the advantage of the what they sometimes coracoid transfer is a bigger name for it, is that not only did you get that bone block, but the conjoint tendon actually acts as a dynamic sling so as you abduct and externally rotate, you can actually see it sits in front. And it prevents it falling forward, so it's
strong enough to hold that in.
Right, yeah, absolutely.
Because it's got a coracoid breaker.
But the trade-off is that potentially you're adjusting the anatomy, the musculocutaneous nerve. So it's thought to have it's a trickier to do and a higher risk with that.
So one of the things that came out in the webinar, people talk about. Olivia said, "Oh, it can turn into an absolute nightmare," and there was the complication profile was discussed.
Yeah.
How does a latter J go wrong?
I think a latter goes wrong because it's more to do with actually getting the right exposure. And then when you actually bolt it on, first of all, the bone block can fall apart, which is obviously a disaster at the time. But really it's trying to, when you put your screws in, trying to make sure that your screws are sort of going parallel to the articular surface, because you actually have to be incredibly medial, because the actual scapula is at about 30 degrees inclination. So you have to be a lot more medial than you think, which is where the brachial plexus. Yeah, so one of the issues is often the bone blocks put on, but the screws, so it's actually standing proud, or the screws are coming through the glenoid. So most of the issues probably with coracoid transfers is the bone block's too proud, it's angled, or there are issues with the metal work, and it's really trying to get that position on. It's quite a difficult thing. It's quite close to the brachial plexus. So if you're not doing them that frequently, it's a bit of a tiger country or something.
Yeah,
that's where the problem is.
And do they? The healing's pretty good, is it? Would you scratch a little
so
bed to put it on? Do you?
Bit of scratching, or perhaps burring would be a better term.
Bone preparation.
Bone preparation.
Scratchy.
It's basically
that is
scratching
the big
now.
thing, trying to get the thing to heal. But then often one of the things is that the bones tends to disappear as well after time. And the really interesting thing is there've been a number of patients that I've subsequently ended up having to do shoulder replacements on, who'd had Bristow, which is a Bristow procedure. So you just have the end of the bone, and you just literally chop the end of the coracoid, and you just put one screw to bolt it on, so you don't get so much of a bone block.
So no conjoint tendon.
No, the conjoint tendon. So it's really conjoint tendon. So
Okay.
apparently, when Latarjet when they first did it, they used to take the conjoint tendon and sew that onto subscapularis, and thought that would do the trick. And I thought, well, actually, it might be better if we take a bit of bone, we can actually
Bone healing.
So it went the other way round. And then the Latarjet is where we'll have a much larger chunk. So we've got 2 centimeters. So the Bristow was the forerunner of that. And actually, when you're coming to do a shoulder replacement, think, this anatomy is going to be really deranged, so I'm really expecting the worst. But pretty much every time, when I've scoped people when I've done revision stuff, I've noticed that the conjoint tendon seems to have come off and stuck itself onto the front of subscapularis, sort of blended into it.
Which is kind of what you wanted.
Which is what you wanted. So I think ultimately down the line, what probably happens is that the conjoint tendon blends itself onto subscapularis a few years down the line, and then you're just left with the bone.
And when you get an MRI or a CT of someone who's had a Latarjet, where does the humeral head sit? Does it sit in the glenoid concentrically, and with your extra bit of bone stuck out the front, lest it when it tends to drift, or does the humeral head kind of move to then centralise on your bone block?
Well, the bone block is replacing a missing bit. So in a way, it's not. It sort of extends it slightly, but it's not actually sticking.
It's not a projection out the front.
Yeah, if it's projecting out the front, then you probably
like a unicorn.
You probably didn't need to do it because there was enough bone. So it's half replacing the bone. So it's not.
If it helps, I honestly thought it was a really good question. Subsequently, it's gone to shit. At the time, I was nodding along, going,
yeah. That's an entry level sort of medical school question. Yeah.
So that's a first year med student, right? No, so with the Idinhibine, are you? It's just bone, no tendon.
No tendon.
Right, so you're just taking bone. So it's just a block.
It's just a
Stay
block
there
that you bolt on.
And you could use horse's hoof.
That's what they're doing now.
Oh, that's awesome.
We
We don't use horse's hoof enough.
Where'd you hear that?
In orthopaedics. On the webinar, you just weren't listening.
So there's an Italian chap who's really pioneered fixing them with suture buttons, actually rather than screws. And they're using allograft, but for some unknown reason, horse allograft, or xenograft they've gone for. Apparently everyone loves it because strong as a horse. But the really interesting thing
I'm familiar with that.
Yeah, exactly. The really interesting thing is the bone is so strong that one of the issues might be it doesn't really remodel as much. So when you use either your own autograft or allograft, what tends to happen is the bone tends to sort of disappear slightly, but it tends to slightly remodel its shape, sort of
so it smooths off.
Smooths itself. But the horse thing is absolutely rock solid. But
who's using horses?
The
French
no,
love
it's the Italians, and and some of my colleagues in the UK would like to, but we haven't quite got approval yet.
The $1 million question: should we be doing Latarjet in everyone in a contact sportsman?
I think if I was in France, I'd definitely. Well, they are. I think it's a really difficult one, as Len said, because a lot of the guys that you'd really be aiming that at are people who are, 14, 15, 16, and it is quite a it's quite a big procedure. I tend to do it because I know it's going to be the most successful thing.
Because it's the most secure thing, but it could be overkill for
could be overkill.
Patients.
I think that, funny enough, although the Idinhibine has been described, I was actually just recently doing a talk, and it's amazing. So actually, if you've got a failed Latarjet, you do an Idinhibine.
Yes.
If you've got a failed Idinhibine, you do a Latarjet. So actually, apart from the dynamic sling, which there's no difference between the two, but if you go onto PubMed and you put down Latarjet procedure, something like 1,500 citations.
Million.
Eden Hibernate, there's less than 40, going
Yeah.
back till
So no one can
19.
spell it.
So no one can spell it,
Yeah.
but
Was
it's
it- was-
actually
is it-
something that people just, I don't think they like
Yeah.
doing that. But I think there's probably going to be a move in younger people that perhaps it's better if you, particularly if you're maybe using allograft to sort of bolt that on without distorting their anatomy. So that might be something that's going to come in.
I like that.
Cash, Eden Hibernate, one dude or two?
I don't know. I didn't
Got him,
check.
got
I
him.
didn't check.
It's
I'm
got to be
embarrassed.
two. It's got to be two.
It's
hasn't
got to
it?
be two.
Oh, we don't know.
I'm going to find
Yeah.
out. You
Yeah.
keep talking.
Uh,
One thing are you going to ask a question?
There you go.
Latige, given that you scope everything, I assume you do them arthroscopically.
You can do them arthroscopically, but it's turned out that the results are no different if you do them open or arthroscopically. And I think the reason behind that is that when you do an arthroscopic Bankart repair, what you're able to do is you can do your operation without having to go through subscapularis. So it's actually a different operation from an open Bankart repair, and people have got better at that. And I think the issues with loss of external rotation have decreased. So really, it's almost a historic. It's very rare that people are doing open. Our technique has got so arthroscopic Bankart is just as good as open. But with the arthro-latige, I think people just assumed, doing this arthroscopically, it's going to be sexy and cool. But actually, when you walk away from the patient and you didn't know which operation had been done, whether you did it open or arthroscopically, they'd be exactly the same on the inside. So there hasn't really turned out to be a big advantage with regards to outcome. It's technically a much harder thing. It's harder. It takes quite a bit of a learning curve to do arthroscopically. And you need to do a sort of certain volume. I've got a pretty high volume practice, so I really got up to speed on them. But for, I'd say a lot of people, they're not necessarily doing a massive number of laches, say maybe 5 or 6 a year. And you probably need to do sort of 10 of those arthroscopically, sort of back to back to get up to speed. So
There's a learning curve.
there's a learning curve, and if there's going to be no difference in your results,
What's the point?
why? So I don't really. I do them. I tend to only do the arthroscopic ones mainly to teach my fellows now, because actually I can do it open faster, and the results are just the same. So it's probably died a death. It hasn't really got a benefit.
Okay, and is that just your experience? Was that the shoulder community?
Shoulder community in general. I mean, I think there are the diehards, the guys that there's a couple of French guys and some German guys that are really doing it. But I think if you were to speak to most people, even the guys that took it, even when it started in the UK, there are only about 5 or 6 of us that really got into it.
Yeah.
And there's probably, I'd say, I don't think any of us are now doing that as our go-to procedure. I think most people have gone back to open.
Pete, I can't find who Eden Hibernate is. So if someone can tweet us,
Love
we'll
to know.
give you an orthohub T-shirt. Have you got any? No. We'll make some. We're getting merch. We're going
to get some
I think
merch.
you're missing out on a trick there.
We are.
Hoodies, the whole lot,
caps,
whole shebang.
We were going to get some gnomes.
Yeah, that was the thing. Some orthohub gnomes.
Gnomes for all speakers.
But our supply's been cut off because of COVID and Brexit.
The gnome supplies is
The longer that lasts, the better. The last thing I want to see is
Tell me
gnome.
what a remplissage is. And who? I take it remplissage is not a dude or a person. It's a description of a thing.
I think it's a French phrase, I should imagine, for filling in a hole, because that's what it. Well, who knows? So remplissage is sometimes if someone's got a Hill-Sachs lesion at the back, what you can do is the infraspinatus. If you actually push the infraspinatus into that, you decorticate the bone and actually freshen up your infraspinatus. You can sort of get it to stick into that. So really what you're doing is you're getting the edge of you're bringing the infraspinatus just a little bit forward into that defect.
Gotcha.
So when you bring your arm round it won't engage because the infraspinatus in that. So some people will do, rather than doing, so a lot of all that bone block stuff is addressing the problem at the front, where you've got glenoid. But if you've got a Hill-Sachs, that is a minor way of addressing a Hill-Sachs. So sometimes you could do perhaps a remplissage and a soft tissue Bankart rather than doing a bony procedure.
So what we're talking about now is getting into the revision setting.
Well, you're getting into the Hill-Sachs setting.
Yeah. So Hill-Sachs probably is Hill sacks, everyone has got a Hill sacks to a greater or lesser extent, almost by definition. When you have a traumatic dislocation, it's really the size of them, but it's so someone who's got a slightly bigger Hill sacks that you're going to try and do something at the front, but you can't really ignore it. It's it's a bit of an elephant in the room, so you think, well, I better do something about that. The next step after that, if you've got a massive thing, is you've got to put in a bone block or allograft. You're going really big after that, so it's something to address the Hill sacks.
Can you tell us about the Stanmore Triangle? Because I assumed it was like some wooden area between Brockley Hill and Bolsover Street, full of Range Rovers with steamed up windows.
I think
some remplissaging going on.
A lot of remplissaging.
Yeah, some bloke called Eden Hibney lives around there. Yeah. So Stanmore Triangle is really what we were talking to about instability of the shoulder. So back in the day, instability, you either had the Tubbs or Ambry, so traumatic unidirectional, and then they thought.
Do we not use those terms anymore?
They've sort of gone now,
right.
And so it's been replaced by the Stanmore Triangle. So it's got that extra muscle patterning corner to it. So
three polar types.
Three polar types. So you've got the traumatic type, you've got an element of laxity, and then you've got this muscle patterning. And actually, within that triangle, you can have a tendency to have various bits. So actually, if you do have a traumatic dislocation, what can sometimes happen is you develop an element of muscle patterning to try and compensate for that. Yeah. So if someone's been got a traumatic dislocation, you fix them up, you may have to really get them better. You may want to work on their muscle patterning and that's sometimes where the rehab after a stabilisation is important. A lot of people who've got laxity may develop a bit of muscle. So it's just a really way to think that there are three possible causes for instability, but actually they're not mutually exclusive. So sometimes people can have more than one thing. So if you're not really successful just doing fixing one bit of it, you've got to think, well, maybe there's an element of something else.
Okay, right. And that third corner, so the Ambry corner, if you like, what's usually laxity. Yeah. Are there other anatomic things which can make you want to dislocate? I mean, if you've got glienoid version, or you've got maybe a dysplastic humeral head,
so that would be, so really the laxity. So I suppose that's not really. I mean, I suppose an anatomical abnormality due to hyperplasia of the glenoid is probably not quite really included in that. That's just a deformity that causes that. That's a sort of congenital type of thing. Yeah. Yeah, so I don't think that's necessary. Good question, that. Maybe we'll have to put a negative. Yeah. Could make it into a pyramid. I don't know.
Yeah. the Bates pyramid.
The Bates pyramid.
Pyramid. There you go. We're getting there.
Smashed it.
You'll knock Stanmore off their perch.
Yeah, absolutely.
You do a beautiful, what you think is a beautiful, I'm just conscious of time. No, I'm not going to ask that. I'm going to ask something different. I feel like shoulder surgery has changed a bit over the last since I was a trainee. Yep. I remember when I was, when I was a registrar in my shoulder clinic. Basically, everybody that I saw had a diagnosis of impingement, and
everybody,
literally
positive.
Everybody, and if it wasn't arthritis, it was impingement. And every operation we did, literally everyone was an ASD. That was the only
five on a list.
Right, and there was only one operation.
Yeah, so I think
with or without excising the ACJ.
Yeah, so I think things have moved on. So I think the first thing is imaging is probably the thing that's made the biggest difference, because MRIs are much more frequent and ultrasound scans. So impingement probably doesn't really probably the classic impingement that Near described, where you're actually sort of probably people now talk about intrinsic and extrinsic causes, and actually most of the pain, it's rare that it's actually really rubbing on the undersurface of the acromion. It's more to do with degenerative sort of change. So impingement is really more, it got a supraspinatus tendinitis, and actually between 60 and 90, 120 degrees, it's tending to catch. And I think it was just fortuitous that a decompression seemed to help a lot of those people. I think there's still a very small group of people who don't have a cuff pathology. So actually the number of just decompression patients I just do a decompression on now is really, really diminished. Most of them have got an associated rotator cuff tear or a long header bicep sort of pathology. So actually, the indications have really dropped down.
And that's interesting. As the number of ASDs gone down, the number of rotator cuff operations has gone up.
Of course,
almost proportionally.
Exponentially. Fair enough.
Yeah. What are the odds?
I mean,
Yeah.
Especially the
It's funny
insured.
I mean, what was the sort of response of the shoulder community to Andy Carr's study where he was doing sham scopes versus real ones?
That's a good question. I think initially people
If you swear,
were a
I
bit
can edit
disappointed
it out, don't worry.
the
What-
word Turkey's voting for Christmas.
Just tell us exactly what he did and what the study was.
Because Pete hasn't read
So
it.
he's done two. So he did a seesaw study, which is the one to see whether decompressions really made a difference. He also did one where he looked at open or rotator cuff, doing rotator cuff repairs or not with him. So really, he was sort of saying that there wasn't if you treated someone non-operatively over time, eventually they got just as good a result as having a decompression. So decompression was a bit of a sham sort of procedure. But actually, probably if you were to speak to most shoulder surgeons, as time's gone by, the number of times that you just scope someone's shoulder and all you do is a decompression is really diminished. So actually, most of us probably say, well, actually, that's probably true. It's very rare that someone's got just
Out and out impingement.
Yeah, just a
Mechanical
tendon. All they've
impingement.
got is just tendonitis, and so they haven't got any pathology. You don't need to repair the tendon. You don't need to debride anything. You don't have to release anything. There's no other thing going on. All I'm going to do is just to chop that little bit of bone off, and hopefully that would do the trick. But there still is. So it's actually not that many people just do decompressions anyway. I think one of the problems is the inadequacy of the codes that are available, both privately and the HRG codes on the NHS, don't really take in. So they think there are not really enough codes to cover all of the things that you can do, and so sometimes you just have to give the code that's the most convenient. So often the decompression code is the one that things are coded for, and it's got a bit of a bad rap. The one area that there is still a group of people that it's difficult to say to a patient, you've tried everything, you haven't got a rotator cuff tear, you've had tons of physio, you had loads of cortisone injections, you're still in pain. You've got impingement, but we've been told a decompression doesn't work. We're not allowed to do that. Yeah. And the patient will go, look,
FFS.
Just give
something.
So it's one of those difficult things that it's all very well saying, in theory it doesn't, but when you're faced with someone who's tried everything else and you're trying to say to them, look, we're not going to do it.
We find something very similar with meniscal tears, kind of people in their 50s, 60s. It's not a thing that you do very often at all, but when you've tried everything else and there is some pathology there that matches their symptoms, it's difficult.
Yeah.
How many cortisone injections can you stuff into someone's subacromial space before you've got to get in there?
So personally, I a lot of the time I'll often try a single cortisone injection if they haven't got older people, even if they've got cuff tears, because there's a lot of asymptomatic tears out there, and often they've been long-standing. So you see a patient whose symptoms have started, you'll look at the scan and you can see they've got a tear. Clearly that's been there for many years, but something's tipped the balance, so you can survive.
Gone from compensated to decompensated.
Yeah, so sometimes I think perhaps a cortisone shot, if you can just tip them the other way, well, that's an easy win.
Agreed.
But it's sort of something you can't be doing it every 3 months, or if it doesn't really work. So I think age of the patient. So as a general, I'd say to patients, I don't really want to do one cortisone injection. If you don't get a decent result from that, then it's pointless continuing. And if someone keeps going, well, that was great, doc, 6 months ago, can you fire in another one? Then I wouldn't be doing that. And there is some theory, if you do a cortisone injection and then try to do a cuff repair within 3 months, it could be detrimental to your surgery. So you've got to bear that up in mind. But once again, it's just practical. You've got patients there, they're in absolute agony, they probably aren't going to want surgery. You just...
The other thing it'd be remiss of us not to talk about is this kind of elephant in the room, which is your A&E frequent flyers. The people who can pop the shoulder out at will and will go do a tour of different A&Es for what back in the day was a bit of pethidine.
So that really is that's the sequencing people as a general, and
So you mix that with a bit of a personality disorder, and you've...
Yeah, I think there's an element. So I think it is, because they are looking for attention, and I think everyone's got a lot more robust now. I think the A&E departments know about it. I think it's really the physios getting a lot more involved, and I think actually engaging with these people earlier on, and perhaps sort of speaking to them, getting them to see physios, sort of basically saying, well, there's no surgery that can be done. It's a really difficult sort of situation.
So there is no surgery that you would offer?
No, they can get better as really exceptional circumstances, but it's really not a surgical problem.
No.
It's a physio, and as you say, partly a sort of psychological thing.
Yeah, multifactorial.
Yeah, and I think just in general, I think just as a medical profession, including physiotherapists and psychology, just the way the A&Es work. Certainly, maybe 10 years ago, there were always a couple in circulation you knew about, but actually thinking about it, I haven't really come across anyone for a while. So I think there was some other things in play that would bring these guys into A&E.
And we've also got a lot better, I think, at working with physios, haven't we? And this kind of multidisciplinary way of working has really changed.
But certainly, I mean, the nice thing in shoulder physio, there is stuff that just only the physios. So they've got their bit. I just can't do that, and and they can do things that we can't do. So
there's genuine expertise and within shoulders.
Yeah, so there's no point in defending that territory because it's not my territory.
Yeah. Patellar tendinopathy, most important joint in the knee. Nothing else matters. Anything you want to ask?
We should probably wrap it up there. Have we missed anything out, Graham? We were
I
expecting you to...
No, I think you've done I think it's good to get rid of some of the myths, show that there may be a little bit of thinking behind it. You don't know. And the best thing is, it's great. It's a bit like in the land of the blind, the one-eyed man is king. So you're assuming, just because I know a little bit more than you, you're assuming what I've told you is correct. I hope it is.
Well, you talked a good game.
I've talked a good game, yeah.
Well,
exactly.
It's
like being an anatomy demonstrator.
I was massively won over.
1 page ahead.
1 page
ahead. Medical students. You can appear to be pretty impressive.
Yeah. We've got, don't worry, Len Funk will correct us.
Yeah, I know. That's what I'm worried about. Yeah.
And
Hannah,
yeah. Graham, thank you much for coming down.
Guys, it's a pleasure.
It. We're going to let you catch the Hogwarts Express back to Cambridge.
And I'd just like to congratulate you on what you're doing with the OrthoHub X-ray. Yeah, I think it really is fantastic, and the best of luck to you.
Thank you.
Brilliant. Thanks so much.
We'll have to get him a t-shirt now.
Yeah. That's what I want.
He's getting a fucking gnome.
And I just, it's just for any of the listeners out there, I've been a little bit involved with websites, things like that. It's not as easy as just come out with an idea. It is so much time. There's a lot of money involved, which I'm sure you guys
come out of their own pockets.
Yeah, it's not quite as straightforward. It's not I've come up with a great idea, I just put something on the internet and suddenly it's a ton of work. And I know, speaking to Mike and you guys, so I really commend you for doing all this. This hasn't happened just on its own. There's a lot of work going on in the background.
Well, thank you. I really appreciate that. Those kind words make it worthwhile.
Yeah.
Pete, can you tell the good people at home who our next guest is going to be? It's a big one.
Oh my God! It's Mo Bandari. No, I'm a bit scared, if I'm honest.
He is what the North Americans call a phenom.
A phenom? Is that
phenomenal?
Is that a bit like a big cheese?
A massive
Or
cheese.
is that a legend?
A legend.
Yeah,
He's a legend. He's the grandest of the grand fromages. Pete, I'll see you next Tuesday.
See you, buddy.
Thanks, Graham.
Thanks, guys.
Have a good day.
KLF is gonna rock you.